This is where we're going to be talking about philosophies of care. And there's basically two philosophies of care that I'm going to be addressing today, harm reduction versus abstinence-based. And you'll notice that I have purposefully put them in quotation marks, and I will explain why. So the first place, well, first of all, I'd like to welcome you back to the Echo after a month's absence. I'm glad. Thank you to the state for refunding us, and thank you to all of you for participating at this very early hour. And I'm glad to see a lot of friendly faces online. So let me start by saying that. Good to be here. So want to start out with the issue of patient engagement and talking about how patient engagement can be related to your philosophy of care. So when you meet people for the first time, they're going to be coming at you in a different stage of change, depending on where they are in their journey. So some folks might sort of say, I really don't need this. The judge is forcing me to be here. Other people might say, look, I really need help. Other people might be somewhere in the middle where they'll say, well, I will take the medicine, but I won't go to IOP, or the exact opposite. I'll go to IOP, but I won't take the medicine that you have to offer me. And so again, it's important for us as treatment providers to be prepared for patients that are in different stages of change and to know how to engage people at those different levels. So that's a little bit why I start with this particular topic. So for me, and we will be getting into this more as we go forward, it's important to have some key questions that you can ask your patients in terms of what matters to them, what their goals are, their importance level and their confidence level as far as change. And one of my very favorite questions, which is, okay, if you're not willing to do this and you're not willing to do that, what is it that you are willing to do at this time? So sort of leaving that door open for the patient to tell you, like, okay, this is what I am willing to do. And then I always try to meet them halfway or a little bit more than halfway. And I just try to pull them along gently. So that is my basic my basic approach. So as I mentioned, there are two basic philosophies of care, which I believe, happen on a continuum from A to Z, which is broader than a continuum from 1 to 10. And that's also very deliberate because I think there's a lot of room for a lot of different ideas about this. So on one end is the quote unquote harm reduction end of the spectrum, and on the other end is the abstinence only. And so again, I don't think that these are the perfect words, at least in English. There may be perfect words in other languages that I'm not aware of, but hopefully as we go through, you'll get the idea of what I am talking about. But the reason that it's important to talk about it and to consider your own personal philosophy of care, as well as the philosophy of care of your program, is because of the implications that philosophy of care has in every aspect of treatment. And so just as a starting point, three very important areas where philosophy of care matters is drug screen results and what that has to do with program participation, and attendance in your programming and what that has to do with whether or not you decide to continue medications. And then if a person decides to not adhere to your treatment plan, what that does in terms of their participation. So just to give you a little bit of a background, again, I've been around so long that when I was in medical school, every IOP program that I witnessed worked something like this. So you would come into the program, say you were an alcoholic and you were also using cocaine, and you would get drug tested 3 times a week. And if you drank or if you relapsed on cocaine while you were in treatment, you were basically kicked out of treatment. So that is the way that the programs worked. So there were no, there might be 1 strike or 2 strikes, but it was basically, a couple of strikes and you were out. And why don't you come back to treatment when you're actually serious? And, what's the matter with you? Don't you get it? That was sort of that's how I was raised as a medical student. And so it took me until 5 years post-medical school when I met the wonderful Sybil Marsh, who taught me about something called motivational interviewing, that I finally realized that, wow, I haven't been doing this the right way for all these years. and that there's another way of looking at the world through the lenses of motivational interviewing. And that's when I started to slowly realize that there was different philosophies of care. So I just want to sort of put that there by way of introduction, that I also was raised in the same soup, in the same mix that many of you were raised in when you were trained. So, and I bet John Ellis probably has some very interesting stories about that as well. So, in fact, I know he does. So I guess what I would say is that for a program to be successful, first of all, everybody that's on the team needs to have some self-awareness about their own philosophy, and then there needs to be some sort of consensus amongst all the team members, okay? So here are some ideas. This is not a perfect chart, obviously, but it just gives you an idea of how these things would play out in day-to-day life in a treatment program. So on the harm reduction side, there's this belief in the quote unquote disease model of, the brain, that this is an actual disease like diabetes or cancer, and it ought to be treated as such. And there are folks that are on the far other side of the continuum that may see addiction simply as willful bad behavior. Or if they see it as a brain disease, they believe that, yes, it's a brain disease, but the only potential cure and the only cure is abstinence. Okay. And so, again, I'm not saying I totally disagree with that. I do see abstinence as the long-term goal, but the way that a lot of programs, unfortunately, are still run in the United States is that unless you commit to abstinence today and for the entire time that you're in the program, well, then we can't help you. And so that makes it a little bit difficult sometimes for somebody that's trying to get well. The other thing where you see this popping up is with the drug screen results. And again, I also grew up with the language of clean urines and dirty urine. And if you had a dirty urine, you were discharged and you were told to come back when you're actually serious about getting sober, which is, I think, a little bit rude, because we don't tell people with high blood sugars, hey, why don't you come back when you're really serious about your diabetes? Like, we never say that to people with diabetes, or we never say to somebody with cancer, well, hey, you're not going to chemotherapy and you clearly don't care about this, so why don't you come back when you're serious about treating your cancer? Never once in 25 years of being a doctor have I ever heard anybody with cancer talk to like that. But almost every patient with addiction that I know of has been treated badly by the medical system. So I get it, it's there. So what I've learned in doing harm reduction philosophy of care over the years is I've learned to actually be aware of my language and change my language. So now I try not to say dirty urines and clean urines. What I'll say is, oh, I see that we've had an unexpected urine drug screen result here. That's it. And it's a non-judgmental term. So unexpected either means I don't see the Suboxone that's supposed to be there, or I see something that is not supposed to be there. Either way, it's unexpected and I can handle it. And you don't necessarily get kicked out. See, that's the difference in the two philosophies of care. The other big difference is that when a patient is being non-compliant or non-adherent with the treatment plan, which basically means that they're disagreeing with the therapist and doing what they want to do, i.e. they're kind of being human with a disease. So when they're sort of being themselves and doing their own thing, that is on one end of the spectrum seen as breaking rules and violating probation, and I'm going to tell your PO and you're going to go to jail and you're going to pay for this kind of thing. Whereas on the other side of the world, somebody that is not adhering to the treatment plan, we might look at the treatment program and the treatment plan and say, what can we do to increase the support around this person so that they can have the tools that they need to stay sober or get sober and stay sober? So again, totally different mindset, and it's a different paradigm. So, and again, if harm reduction is the Z and abstinence only is the A, you can see that there's 24 other letters in between, so that each of us can have a very sort of fine-tuned or fine-grained place where we stand on that continuum. So there's things that we're willing to do, things that we're not willing to do, and so on. And our fellow counselors and our fellow doctors and nurses might have a different opinion on those things. And my point is, it's important to know what that opinion is. And I love this. I don't know who the author of this quote is, but I love the quote. And basically it is about the glasses and the glasses that we wear and how we see the world. So what you see in the patient sitting in front of you depends on how you view the world. To most people, this is just dirt. If you are a farmer, it is potential. So most of my patients have been looked at as dirt and scum of the earth and the lowest of the low. And I just tend to see them as people that have a disease and they all have the potential for recovery. So the way that you view people, again, affects the way that you're going to treat them. And again, that's very obvious. That's been obvious to most of us probably since we were 5 years old, right? So your how you work in the world depends on your point of view. So now this is the time at which I usually ask for a volunteer to read case example number 1 and case example number 2, mostly because I get tired of listening to the sound of my own voice. So if I could have a brave volunteer to join me with helping out with this part, I would love it. So yes, I see somebody.
Susan's hand is raised.
Raising a hand, go for it.
Case example 1, DM is a 30-year-old sugar addict. He was arrested yesterday for sugar possession with intent to traffic. He brought donuts to his job. He had 4 previous dirty blood tests with an HbA1c of over 10. If he has 1 more dirty blood test, he will be discharged from the clinic because we only treat sugar addicts who can keep their HbA1c below 7. He will be sentenced to 90 days of intensive nutrition class and have 4 random blood glucose checks weekly. He also needs to attend 3 Donuts Anonymous meetings per week and get his sheet signed. If he overdoses on sugar again and goes into diabetic ketoacidosis, is that right? He will get charged with sugar possession. After he gets out of ICU, he will go straight to jail for a 30-day stay. That will teach him to never eat sugar again.
Thank you. And I'll do the next slide. And this is case example number 2. And again, I'm looking for a gracious volunteer to just take us through this case. So
I'll do it.
Thank you.
I think I did this before. I should know this person. SUD is a 40-year-old woman with opiate use disorders. She overdosed last night on heroin. She was admitted to the ICU and treated with grace and dignity until she fully recovered. She was not discharged until she met a peer support worker and a counselor and saw a psych for depression and PTSD. Her buprenorphine prescription was filled. The prior authorization was done. The nurse taught her how to use an naloxone kit in case of another overdose. She had her follow-up appointment with an addiction specialist within 3 days of discharge. A visiting nurse checked on her daily for 1 week to assess her recovery status, medication compliance, and ensure rides to 12-step meetings and IOP. Her family was kept informed of ongoing treatment plan and given information on family support.
Thank you guys so much. And so I present those cases, and you know what's sad to me, having done this for over 2 decades, is that case example number 2 was purely taken out of my imagination because it doesn't actually exist yet. So to me, that's what's really sad. So I actually had to think about what it would be like if my patients were treated the way the person in case example number 2 was treated, because maybe some of the things happen, maybe 30% of the things that are in case example number 2 happen, but certainly not 100% of the things. And so I guess it's disappointing to me, and it also kind of keeps the fire burning in my belly, which is why I keep waking up every day to do this. Because until we have everybody treated like case example number 2, and until we stop treating people like we do in case example number 1, I'm going to keep talking. So that's kind of where I come from. So I'm just going to wrap up and talk about the importance of language. Language is where it starts. I really respect this gentleman named Don Hoyhis, who started his own sort of recovery initiative. He is an American Indian, and so he has lived this firsthand. And he says that words are important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And so all of us can remember when we were kids and we thought like dandelions were these wonderful, beautiful flowers, and we would pick the dandelions and give them to mom and give them to dad and say, oh, I picked you a flower. And meanwhile, the mom and the dad is looking at the lawn going, man, I got to kill all those weeds in my yard. And so something happens to us between the age of 5 when we recognize a dandelion as this beautiful flower, and then adulthood where we're like, oh yeah, that's a weed, that is something to be killed and thrown away. And so again, the language that we use is where it starts. And so Ohio has been working on this for a few years, and they have what's called a language first team. And so this is where I got the materials that I'm about to show you. So in terms of trying to do stigma reduction, they give a little card that you can have in your office as a reminder, not only to you, but your patients and your staff about what types of terms we should use. So instead of perhaps saying somebody's an addict or a junkie, we might want to use the word person in active addiction or person with a substance use disorder. And, or if they are, been sober for 10 years, maybe we get away from saying sober for 10 years and we just say, hey, they're a person in long-term recovery. So we can also look at the words we use and start to change that. This is just, again, another example of some of the Ohio First, some of their stuff that they have on their website. So you're free to go there and check that out. And then I always like to end with this little story here about bring it back to dogs, me and dogs, right? So this is by a woman named Tara Brock. And again, this always helps me to remember to, keep my empathy and my heart in the right place. So imagine you're walking in the woods, you see a small dog sitting by a tree. As you approach it, it suddenly lunges at you, teeth bared. You are frightened and angry, but then you notice that one of its legs is caught in a trap. Immediately, your mood shifts from anger to concern. You see that the dog's aggression is coming from a place of vulnerability and pain. This happens to all of us. When we behave in hurtful ways, it is because we are caught in some kind of trap. The more we look through the eyes of wisdom at ourselves and one another, the more we cultivate a compassionate heart. So sometimes when we run up against people and patients and maybe even staff members who are having a rough time and might be getting aggressive, I sometimes think, wow, maybe they're coming from a place of vulnerability and pain. Maybe they're caught in some sort of a trap. And is there something I can do to try to get them out of it? I mean, not always the case, but often the case. And so it's just enough to make me take pause. So I will stop there. Looking forward to hearing the case and having a great discussion this morning. And thank you for your help to my 2 volunteers.